Good morning and welcome to Health Matters with the Medicine Center Pharmacy. I am your pharmacist, Paul White. We're very glad you joined us. Before we begin, I'd like to thank our sponsor, Aultman Health Systems. Today, Brad and I are broadcasting from our administrative offices, and our special guests are Suzanne Aiken, CNP, and Vicki Valentine, RN, from Aultman Palliative Care. Good morning and welcome to the show, ladies.
Good
Good
morning.
morning. Thank you. Thanks for having us.
Okay, palliative care is a specialized care for people of any age at any state of serious illness. Aultman services guide patients through pain and symptom management while they're seeking aggressive layers of physical, emotional, and spiritual support for patients and their families. We'd like to remind our listeners that our program is available on our podcast. Just look for Health Matters with the Medicine Center Pharmacy, and please subscribe to our program.
Okay. Good morning again.
Good morning.
Suzanne, please tell us about your background and career with Aultman.
Good morning. I've worked for Aultman since I graduated from Akron in 1998. I started on a telemetry floor, worked there for about a year. Then I transitioned to the emergency room where I worked for about 15 years.
Mhm.
As I was finishing up there, I was going to school online for my master's degree at Ohio University. And I graduated from there in 2015 and started with palliative care in August of 2015. And I work mostly for the home side of palliative care. I do a little bit in the hospital. Every couple months I work a weekend in the hospital, but mostly you'll find me visiting our patients in their homes.
Wow. So, good morning, Vicki. What is your background and career with Aultman?
I actually graduated from Aultman Nursing School 1994, and I've done a lot since then, mostly cardiac. Had a lot of nursing home visits for a physician for a lot of years also. Worked for cardiology intervention. I started with hospice maybe about 6 years ago and worked there casually for about a year. And I started this palliative position about 3 years ago as the lead nurse in home palliative care.
So, can you tell our listeners what palliative care is?
So palliative actually means relief of symptoms. So palliative care is a program when there's chronic or life-limiting illnesses, like you might have had frequent hospitalizations or frequent symptoms causing a burden on your quality of life. So palliative care comes into play to help alleviate some of those burdens, whether it's through resource support or symptom management or goals of care planning. Lots of times people just need some help with the direction their illness is going, with education or a little extra hand holding.
So, just for making sure I'm not misusing words, I'm understanding so far from our conversation that palliative care is not necessarily the same as hospice care. Is that accurate?
That's accurate.
Correct.
Okay.
Palliative care comes into play when people are still seeking treatments. They still want to go
Okay.
back to the hospital. Their illnesses still have some management that can be done by doctors and testing and treatments and procedures. Where
Okay.
hospice comes into play when symptoms have become or treatments have become too much of a burden. So people might say, I've had enough, and they're just ready to let nature take its course. But with palliative care, people are still going to get blood work and testing and treatment. And like, for example, cancer, people are still getting chemotherapy or radiation therapy.
Okay. So, do you have any other illnesses that could qualify for palliative care, and how that might look for a patient, just as an example?
So, like COPD, sometimes people with COPD have frequent we call them exacerbations, where breathing might become troubled by the illness becoming, I don't know, exacerbated or
Frequent hospitalizations for the same chronic illness, like congestive heart failure, COPD, lung disease, a lot of dementia, especially end stage dementia, don't you think? With all the symptoms they're having,
or liver
hallucination.
disease is another one, because toward the end stage of liver disease, there's a lot of symptoms that come along with what's going on.
And we offer a lot of community support too, as far as resources. We have a social worker that is super duper in her job, and does help patients find in-home care, extra care, community care, if they qualify for certain in-home care to be paid for, different funds and grants that she knows of that I don't know a whole lot about, but she can help in that situation also.
The social
Okay.
worker can also help with resource allocation, like Meals on Wheels, or she works a lot with Passport or Direction Home, which is like a Medicaid waiver program that will help with supplies like Boost or Depends or aid service, transportation service. So that's
okay. So how does a person get referred to palliative care then?
Most of our referrals are from primary care physicians. The hospital, we have a palliative team that's in the hospital. There is a palliative care tool, I guess you can call it, that triggers a patient if there's been so many admissions, if they have so many chronic illnesses,
Okay.
that says, hey, we need palliative care to consult, and it's just offered to them. It's not something obviously that they have to take, but we get referrals from them, from primary cares, from the families themselves call in. A lot of times insurances.
sometimes home care will be involved with the patient after a hospitalization, and they'll recognize the need for continued support. Because maybe home care is ending and they feel like the patient still needs some, somebody to watch them and keep a little bit of an eye on them. Because their condition might still be a little fragile.
How about this? Is there a cost for palliative care?
So we have a grant program in Stark County called the Milligan Fund. So when a person is visited by a nurse, the Milligan Fund will sometimes pick that up depending on the income. And I don't know what the numbers are, but it's a pretty generous income from what I understand. Now, when, like myself, when I'm a nurse practitioner, I would get billed similar to, depending on your insurance, I should say, similar to a specialist, which is usually like maybe a $30 copay from what I've been hearing. But people with prime time are sometimes, like, their doctors are contracted with prime time to offer palliative care at no cost to the patients. And that's most of the prime time doctors. So that bill will be covered. But usually if they have to pay anything, it's no more than like a $30 or $40 copay.
Okay, yeah.
So how is palliative care different from home care?
So home care comes into play typically when a person has come out of the hospital and they have a medical treatment that needs done, whether it's wounds that need monitored, dressings for those wounds. Home care comes along with physical therapy. So if someone gets assigned physical or occupational or speech therapy, there will be a home care nurse that comes along and, at different times than the therapist, but she'll come to check like vital signs and blood sugars and make sure the medicines are being used correctly. They will usually see a patient like 2 to 3 times a week, depending on what's ordered. And that usually lasts for about a month. Now, palliative care, we only see a patient like every 4 to 6 weeks, and that lasts for a longer period of time. As long as the patient has needs that we're able to service. Now, those needs can be, emotional support, physical symptoms, if their disease process and symptom management isn't well controlled, then we can justify continuing to see them.
Ladies, it's time for our first break. You are listening to Health Matters with the Medicine Center Pharmacy. Okay, welcome back to Health Matters with the Medicine Center Pharmacy. Are you ready for vaccine season? Stop in or schedule your flu, pneumonia, COVID, or shingles vaccine online at midshoprx.com. So, what symptoms are managed in palliative care?
So the traditional symptoms we think about are like nausea, constipation. We manage some pain, but usually if it's cancer related, just because cancer tends to be a terminal diagnosis. So we do manage pain as long as it's related to a life-limiting illness. So like we don't manage arthritis pain. So liver disease that has pain, we would manage that. But there's not just the physical symptoms. Sometimes it's the emotional symptoms as well. A lot of times there's anxiety or depression or spiritual turmoil that comes along with having an illness that's limiting your quality of life. Sometimes people, end up in the hospital and they come out of the hospital not being able to do any of the things they enjoyed in the past. And that causes a lot of, emotional burden. And sometimes it's just the relationship with the provider that will help alleviate some of that emotional turmoil, knowing that they have somebody that they can talk to and turn to.
We do have chaplains.
And we also have chaplains. And the chaplains don't just talk about religion, they talk about the emotional aspects of having a life-limiting illness and how to help them through when your level of functioning is declining.
I mentioned before the show that my sister Beth passed away a month or so ago, and the pastor from Palliative Agency, Aultman, came out, and he was just tremendous. Absolutely.
Yeah, they're all really great.
Yeah.
I forget his name, a young fellow, but he.
Daryl.
Yeah, we have
Right,
three.
Daryl.
Yeah, we have 3 chaplains that work with us. There's Joe, who is a military veteran, Daryl, and Jamie is the third one. But they're all just average people like me and you, and they're easy to talk to.
Yeah.
Like I said, it's not just about religion, it's about this emotional turmoil that affects your well-being.
He was excellent. That's all I can tell you. Excellent.
Do you have anything else you'd like to add about how you help patients manage symptoms in palliative care?
Well, sometimes, it's just an education. Like, so say somebody's constipated, it might just be pointing them in the direction of the right over-the-counter medicine. People see so many ads on TV and it's hard to filter through them. So just pointing them in the direction of what the best over-the-counter medicine is. Sometimes it's, if they have symptoms of a urine infection, it might be collecting the urinalysis and then prescribing an antibiotic for that. Other times it might be working in relationship with their primary care physician and, reaching out to them to explain the symptoms and go from there. Sometimes it's medicine, sometimes it's just talking through things, sometimes it's education.
Okay, we've talked a lot about the patient involved in palliative care so far. How about family members or support members?
Yeah. So I feel like family members get a relief from our service because they like the fact that somebody's checking on their loved one. They like the fact that like if they're out of town or out of state, especially that there's somebody coming to see their loved one and then relating what's going on back to the family. And you can go to the doctors and spend 5 or 10 minutes seeing the family doctor or the specialist, but that doctor doesn't see how the patient's functioning in their own environment. So we get a better picture. Um, we can see the medicines and we can realize, oh, you're not taking your medicines every day. And that might be intentional or unintentional. But family members really appreciate the fact that, we come to see them and then relate to them what's going on, especially if they can't be here in person.
A big part of my job too is really like a triage nurse, I'd say. It's an extra resource for them to call. They can call it, I'm the nurse in the office, that they can run some things past if they haven't been able to get a hold of their primary care physician, or if they not sure if they should take them to ER. It's just another set of eyes and ears, I guess, too, that I do a lot of that, just, trying to listen to what they're seeing. And they can run that past me and I can say, well, we can send a nurse tomorrow, or we can send a nurse practitioner, or you need to be assessed by a physician. So just an extra resource for them too.
So palliative care tries to keep people out of the hospital. We try to limit the number of hospitalizations, but there's just sometimes that you need the emergency room. We can run a urine sample or have you go get some blood work or a chest x-ray, but we don't get those results for a day or two when you do it on an outpatient basis. So there's some time that you just need to be told, the emergency room is going to get your answers and you might need to be admitted after that. Sometimes people are in a state where they don't want to recognize that, or they don't want to have to face the emergency room because it's usually a long wait.
Yeah, it can be intimidating too, especially when you get a patient working with a lot of different providers and there's just a lot of moving parts. I mean, I had a patient call the pharmacy yesterday who was taking two medications that their other doctor had discontinued 2 months ago. And you're right. I can understand how having another pair of eyes helps, because sometimes with the best intentions, you think you're following the directions of your doctor or nurse practitioner, and it just gets complicated. So,
And lots of medicine in the home that they're not supposed to be taking. We
Yeah.
find it's easy to review that, especially in the older people that keep the old pills and the old bottles. And a lot of time we do a lot of, I think, medication education also.
yeah. Well, things are so expensive anymore, they don't want to throw them away. What if you get put back on it, right? I mean, I understand that part, but you're right. It's a delicate balance.
The other thing is, when people are discharged from the hospital, sometimes things don't fall into place. Sometimes, they might have had a medicine prescribed, but they didn't get it. Or they might have had a medicine discontinued, but that wasn't relayed to them, so they're still taking it. Just yesterday, I was reading over, like before I go see a patient, I'll look over their hospital or their doctor's visits. And someone was on Eliquis and they were in the doctor's note, it said that they were going to stop the Eliquis, or he was going to stop the Eliquis. But then he didn't really stop it and the patient was still taking it. Now, granted, he was only there at the doctor's visit the week before, so I ended up calling the doctor for him to clarify.
Yeah.
Eliquis is a blood thinner, and if he didn't need to be taking it anymore,
Right. All right. Well, earlier in the program, you were kind enough to touch on hospice. For listeners just joining us, can you just tell us again what hospice is?
So palliative care, like I said, comes into play when you are still seeking treatment. Hospice comes into play when you've decided treatment isn't the best option for you, whether there's too much of a burden. And you can decide that it's too much of a burden, or your body might be not tolerating it. Like, for example, with chemotherapy, you might have drops in your blood counts that are caused by the chemotherapy. So that being said, your body's rejecting that treatment. But hospice comes into play when you're at the point where you just want to let nature take its course.
You want comfort.
You want comfort and
care.
quality of life over quantity of life. Sometimes I tell a patient, if the doctor tells you you have 30 days to live, but if you're spending 20 of those days at the doctor's visit or at the doctor's office waiting, a half an hour plus to go see the doctor, and it's physically and emotionally burdening and fatiguing. So you go to the doctor, you come home, you sleep for the rest of the day. Is that really worth it? Or would you rather be at home and be able to spend time with your family when you don't have a lot of energy?
So I guess we've kind of answered that hospice question, how different it is from palliative care. What are some common misconceptions about hospice?
So when people are on hospice, they always have the ability to change their mind. Nothing is set in stone. Some people feel like, if they sign up for hospice, they don't have any more choices left. You always have the choice to change your mind and get a second opinion or go back to treatments again, or go back to the hospital.
I think most that I hear, they have to stop all their medications. That's not true. Or you have to take morphine, and that's not true. You're still in control of your journey when you're with hospice. You don't have to stop the medications that you're on. Now, sometimes if they're life prolonging medications, they will, such as chemotherapy or infusions for MS or something like that, that's life prolonging, those would stop, but not the other medications that you're on.
Okay. It is the bottom of the hour. Time for the news. Thanks for joining us this morning on Health Matters with the Medicine Center Pharmacy. You are listening to Health Matters with the Medicine Center Pharmacy. I'm your host and pharmacist, Paul White. This morning, we're talking to Suzanne Eakin and Vicki Valentine with Aultman Palliative Care. Did I cut you off on what we were talking about hospice, or did we get right?
Well, you had asked some of the common misconceptions of hospice.
Yeah.
And, a big one is that it's the last couple of days of life. And that comes, I think, because back in the day, many years ago, people would wait till they were in a crisis to transition to hospice. And they were already in that active dying process. Now hospice is available much sooner to people, and it has the ability to provide support to the patient and family. There's lots of resources that come along with hospice, but that's one of the biggest ones. Anything you want?
Normally, to be qualified for hospice, you should have a terminal illness that's less than 6 months to live, is what the Medicare guidelines are. So,
Yeah.
Hospice is a, how do I say this? Okay, Medicare health insurance. Hospice is a division of Medicare, or am I wrong there?
So hospice is covered by Medicare. Your hospice benefit, everybody has a hospice benefit under their Medicare.
Okay.
So Medicare is covered, or hospice is covered by Medicare. So Medicare sets guidelines. One of the guidelines says, going back to that 6-month life expectancy, after 6 months, if you're on hospice, you need to show some type of physical decline, whether it's need for more medicine, whether it's weight loss, sleeping more, an increase in other symptoms, that would qualify you to stay on the program. After the first 6 months, a person is evaluated by a doctor and nurse practitioner every 2 months. And, you know, you can have a little period of 2 months where you're stable, but for the most part, you have to just show decline for Medicare to continue to pay for that service.
And a lot of patients get discharged back to palliative care for us to follow. They go back to their primary care. They go back, you know, whatever hospitalizations that they needed before. And a lot of times to stay with us until there's further decline and they go back to hospice. So it's not always the end all, but the support and services they provide, it's good.
Is there a maximum amount of time you can stay on hospice?
No, as long as you're showing decline, you know, the doctor has to certify the patient. So as long as there's some decline that they can justify, then the patient can stay on hospice. And sometimes they're on hospice for over a year, maybe
Yeah.
sometimes longer. You know, sometimes illnesses have like a roller coaster of ups and downs with symptoms. And when someone, they call it graduates from hospice, what can happen is they're very sick in the hospital, and then once they get back home and, you know, you take away all the burden of the testing and treatments and going to the doctors, they kind of stabilize. A patient can kind of stabilize, and if they stabilize enough, then they don't qualify to be covered by hospice anymore.
Okay.
So where can hospice services be carried out?
So sometimes people are under the misconception that you need to go somewhere to be on hospice. You can be on hospice at home. When you're on hospice at home, you have a nurse that comes to see you at least once every 15 days. And then you have aides that can come a couple times a week, depending on what your needs are. Now, those aides don't stay for 4 or 5 hours. They're just there to do some personal care, like, you know, help with the bath, help with a little bit of light housekeeping, or help with a meal or something. Now, a patient can be in the nursing home and be on hospice as well. And those hospice people come in over and above the staff at the nursing home. So even though they have aides taking care of them, the hospice aides will do the bathing and maybe sit with them for a meal and help. Like if a patient needs fed, they can just provide some socialization during the meal and help them, you know, carry out those tasks of daily living.
You can also, we also have a compassionate care center, Aultman does, which is where we're at right now. That you can be admitted to for a respite time, like time for the caregiver, maybe to gain some, you know, get some relief of taking care of a patient sometimes, and also if your symptoms aren't controlled at home.
So when you sign up for hospice, you say that you aren't going to go back to the hospital because it's testing and treatment and poking and prodding. But sometimes you have symptoms that aren't managed well at home. So the compassionate care center is, in a nutshell, like the hospice hospital. So you'll see a doctor. To have Medicare pay for that, you have to they have to justify that you have a need where the doctor will see you once a day. That might be medicine adjustment or symptom management of some sort. Usually, like the hospital, it's a short-term stay, like 5 days or sometimes a few longer. The other way you can be there, like Vicky said, is for a respite stay. Say your caregiver was going to have a surgery or a procedure and the family needed help taking care of the patient on hospice. They could be at the compassionate care center for 5 days for a respite stay. Or say the family was just going to go on vacation. They can, you know, they can come to the compassionate care center while the family went on vacation. Usually it's a 5-day covered stay, so there is the option to private pay over and above that 5 days.
Interesting. So, what are the reasons that you might change your mind about hospice once you're on it?
So sometimes people just get into a crisis and they say, or the caregiver might not be able to handle that crisis and they forget to call the hospice team, and instead they call 911 and send the patient back to the hospital. Other times a person might fall and, say you're on hospice for a cancer related diagnosis, but you have a fall and you break an ankle. You would go to the hospital, you'd sign off of hospice when you were in the emergency room. They would fix the ankle, like cast it. You might get a little bit of therapy, but then after the therapy's completed, you have the option to return to hospice. Anything else you can?
I think
of?
sometimes people get scared all of a sudden, maybe haven't coped with the idea that they're terminally ill and they change their mind, and that happens, and that's okay,
Like they panic. So say somebody wakes up, say somebody has COPD and wakes up short of breath and can't breathe, they might panic and call 911 because they forget that they have medicines available to help control those symptoms, and they have a nurse that they can reach out to.
So other places than home that you could receive palliative care?
That you can receive palliative care. Well, if you're at a nursing home, some patients in a nursing home are on palliative care.
We don't follow nursing extended care facilities anymore. There's a group of physicians and nurse practitioners that do see patients in the nursing homes for palliative care. It was just getting a little bit too much for our team to see them also, but you can't have palliative care in extended care facilities. We see patients in assisted living.
But also on that note, like sometimes I'll have a palliative care patient that goes to the hospital and then they go to a nursing home for rehab or an extended care facility for rehab. We will follow them because they're not going to be there long term.
Right.
Their intent is to return back to their home. Also, sometimes people coming out of the hospital will go to an inpatient nursing facility to get some rehab. And then we might, we know that that's just a short-term inpatient rehab. So we would follow them there at the nursing facility while they transition to home, back to home.
Okay, ladies, our final break is here. You are listening to Health Matters with the Medicine Center Pharmacy. Welcome back to Health Matters with the Medicine Center Pharmacy. I'm pharmacist Paul White. Thank you for joining us this morning. Let's get back to the last segment of the show.
Okay, why might the palliative consult team be brought in a hospital setting?
So there's a couple different reasons. If they notice that there's been multiple admissions, the palliative care consult team might be called to help with goals of care discussions, meaning, do you want to keep coming back to the hospital? Is coming to the hospital helping ease the burden of your illness? They might need to help the patient address their code status. So the code status is kind of like a quick look at what the patient wants. So some people have something called a living will, which is like a 20-page document that outlines goals. A code status is a quick one-sheet paper that directs healthcare personnel in how they want treated. Or what other reasons? If symptom management, like pain control, or
somebody's newly diagnosed with a terminal illness or a new cancer or something new, they do, and they discuss goals of care and treatment, and what treatment do they want, or do they want any treatment,
or
they
like
have those conversations.
what to expect with the illness and the treatments.
This is where this is what's gonna happen over the next 6 months or a year or whatever. Yeah, most of the time it's with new diagnoses too.
Okay, what is the supportive oncology team?
So that is a division of palliative care as well, but it's located in the Aultman Cancer Center. And that's led by Dr. Marsh, and Natalie is our nurse practitioner. And they do a lot of symptom management when people have a cancer diagnosis. So to qualify for that, you have to be going to Aultman's Cancer Center to see one of their physicians. And then Dr. Marsh and Natalie help with pain control, nausea, constipation, those kind of symptoms. And they also have goals of care conversations that come along with a cancer diagnosis.
They also have a social worker that works full-time with them for extra resources for the patients, say transportation to all the treatments that they're going to or care in the home. Also, there's a nutritionist, I believe, that's in, I'm not sure if she's in the cancer center or not, but is available that most cancer patients end up seeing just because failure to thrive issues and
Weight loss and
Okay. Sounds like you probably work hand in hand then with the nurse navigators that help patients that are on their cancer journey. So it certainly is a dynamic group of people helping patients and family members get through challenging times.
Mhm. You know, and I think all the different facets kind of complement each other. Like a person might start in the hospital and they're having a lot of admissions, or maybe they have a new diagnosis and they're going to go back home. So that's when the home palliative care team might come into play. Or if they're going to be referred to the cancer center, then, the supportive oncology clinic might come into play. Just so that way there's continuity of care.
Okay. We have a couple minutes before we wrap up. I wondered if each one of you would be interested in sharing what's so rewarding about being part of the palliative care program for you personally.
When I used to work in the emergency room, like I said, I worked there for 15 years. We'd always see a patient, and the really sickest patients we would send, I don't know, to the ICU or to the floor, or, if it was a child, we would send them up to Akron Children's, or they'd be sent to Cleveland Clinic. But we never found out if what we did mattered. We never found out like what was the end result of the care we gave. Where with palliative care, we know what their journey's been. And we are, kind of helping them navigate, with a terminal illness or a long-term illness toward the end of their journey. And I just feel like seeing the patient in their home setting and meeting them where they're at in their illness is rewarding, just because you develop that relationship. We have more time than the doctor has in their own office. They might be scheduled 2 patients in a 15-minute slot, where we have an hour and we can see, what resources they have available to them. You can tell that just by walking into someone's home. Maybe they don't have the functional ability to, vacuum their carpet every day, or maybe they live in this grand house and they have more resources available to them. So it just gives you a better, more holistic picture of the patient. And the ability to, visit them for a longer period of time helps you develop that relationship.
I do.
Seems.
Oh, go ahead.
Go ahead. No, I'm sorry. Go ahead.
I was just gonna say, I feel like I've done a lot in my career, and being in the hospital, seeing how much education probably didn't get done from the physicians, the nurses, the aides, everybody, the therapists. You try to get all that in. There's so many people coming in and out of the room. The family isn't always there, and here's half the conversation. I feel like on this end of it, the first conversation that I have with them are the questions they have about palliative care, because I'm calling to set up, for us to come out and get them started at home with palliative care. And so many times they didn't hear what it was, or they have a misconceived notion. I like to be that person. That could be about palliative care. It could be about their discharge plans with therapy. It could be about their future appointments. I feel like I can be a navigator with that, because I'm able obviously to see their hospital stays, what went on and what they're concerned about. I like that part of it also. I feel like if patients question palliative care, call anytime. We're here Monday through Friday, and just ask. It doesn't cost you anything. So
It seems to me that there are periods of time when you are just absolutely not able to handle so many patients. What do we do then?
We have probably about 300, or we around 300, and we
Yeah.
have 3 nurse practitioners. Our nurses don't do regular visits, but we do
Gee.
have 3 nurses. And they get seen, we try to see them right after they're discharged from the hospital. I think the amount of patients has always been a challenge, even in the hospital. Same as at home too. There's so many, especially with dementia, lots and lots of family members needing help with that. You could be as big as you wanted to be if you wanted for palliative care, really.
Yeah.
Wow.
Hmm.
I think we're out of time, right, Brad?
Yep, we
Okay.
are. Thank you.
Thank you to our guest, Suzanne Aiken. Vicky Valentine, if you suspect you have a medical issue, please contact your healthcare provider. Thanks to Aultman Health System and our listeners for joining us on Health Matters with the Medicine Center Pharmacy. Have a healthy week, and we'll see you again right here next Friday on News Talk 1480 WHBC. Thank you both very much.
Thank you. Thank
Thank
you.
you.
Have a good day.
Thank
Very
you.
interesting. You too. It's raining, I think.
Thanks.
Okay. Take care.
Bye
You as
bye.
well.
Thanks, ladies.
Thanks.
You too.